thyroglossal cyst. So just break this word, thyro plus glossal plus cyst. It means there is a cyst in relation to thyroglossal tract. So have a look. What is thyroglossal tract? It starts from foramen cecum. Then there is thyroglossal tract and there are two lobes of thyroid. Now what happens? There is one bone in relation to this thyroglossal tract and the name of bone is hyoid. Most common location of this thyroglossal cyst is just below the hyoid, that is subhyoid. Other locations are suprahyoid, near thyroid cartilage, near foramen cecum, in the floor of mouth. So I'm repeating the important points. Thyroglossal cyst is congenital anomaly, but age of presentation. The age of presentation is 15 to 30 years. You can see locations. Most common location is subhyoid. Other locations are suprahyoid, near thyroid cartilage, beneath foramen cecum, and in the floor of mouth. And the question which is important, most common location of thyroglossal cyst, that is subhyoid. Now you can see that actually directly or indirectly it is connected to what? Tongue. Why? Because thyroglossal. Thyro means thyroid, glossal means tongue. So can you see, suppose this is the tongue. What is the problem? Just like any other thyroid swelling, there is a midline swelling in the thyroid which moves with deglutition and it moves up on the protrusion of tongue. So the important points are, there is midline swelling in the anterior part of neck which moves with deglutition and it moves up on protrusion of tongue. And I told you it's congenital, but age of presentation is 15 to 30 years. Now see the complications. What is going to happen in this thyroglossal cyst? Sometimes there is infection. Because of this infection, there is abscess. And if incision and drainage is performed, it can lead to thyroglossal fistula. Be careful. Thyroglossal cyst is congenital, but thyroglossal fistula is acquired. So see the complications. Complications are infection, abscess, and incision and drainage of abscess leads to thyroglossal fistula. It increases the risk of one malignancy, and that is papillary carcinoma. This is very important question. It increases the risk of papillary carcinoma thyroid. Right? Now see how we are going to treat this condition. Okay? Now see the diagram again. Very simple. Have a look. This was the thyroglossal tract and this was foramen cecum. After that, there was one bone in relation. This is hyoid. Now, this is the cyst. What we are going to do, since there is passage of tracts via the central part of hyoid bone. Can you see? There is passage of tracts via central part of hyoid bone. So we are not only removing the cyst, we are also removing this part of hyoid bone. So what is the treatment? Treatment is cyst trunk operation. And what is this cyst trunk operation? This is en bloc removal of cyst with central part of hyoid bone. Central part means body. Central part or body of hyoid bone. So this is cyst trunk operation. After that, question is asked, how will you treat thyroglossal fistula? What is the definition of fistula? Fistula means communication between two epithelial lined surfaces. If there is fistula, we have to excise the fistula tract. So for thyroglossal fistula also, the treatment is same, cyst trunk operation. The treatment is same, cyst trunk operation with excision of fistula tract. So this is the treatment for thyroglossal fistula. This is the congenital abnormality. Retrosternal goiter, also known as substernal goiter, also known as mediastinal goiter. So whenever more than 50% of thyroid gland is located below neck, that is known as retrosternal goiter. So definition: retrosternal, it is also known as substernal, also known as mediastinal. Goiter. Definition: when more than 50% of thyroid tissue is located below neck. Right? Now have a look. When more than 50% of thyroid gland will be located below neck, what is the problem? Just behind thyroid gland there is trachea. Behind trachea there is esophagus. And in between tracheo-esophageal groove there is recurrent laryngeal nerve. What is good thing about this retrosternal goiter? That most of the patients are asymptomatic and usually detected on X-ray. But when the size is big, sometimes patients are symptomatic. And these symptoms are because of compression of trachea that can lead to dyspnea, compression of esophagus that can lead to dysphagia, compression of recurrent laryngeal nerve that will lead to hoarseness of voice, and compression of veins which are going to drain the face, leading to dilated veins in the neck and in front of chest. And Pemberton sign is positive. So what are the manifestations in severe cases? First, dyspnea and stridor due to compression of trachea. Second, dysphagia due to compression of esophagus. Third is hoarseness of voice, that is also known as dysphonia, due to compression of recurrent laryngeal nerve. After that, there is dilated veins in the neck and in front of chest, and Pemberton sign is positive. What is Pemberton sign? When the upper limb is elevated above forehead, there is facial puffiness, faintness, or dizziness. This is Pemberton sign. I'm repeating. When the bilateral upper limb is elevated above forehead, there is faintness, facial puffiness, dizziness. This is Pemberton sign. So all these are suggestive of compression of the structures in the neck. Now, how to treat this condition? Which incision is preferred for removal of retrosternal goiter? Options: cervical incision or thoracic. Now see, the blood supply of thyroid gland is mainly from the cervical region. And if blood supply is mainly from the cervical region, what is preferred? It is easy to ligate the vessels by cervical incision. And that's why treatment is thyroidectomy, and the preferred incision is cervical. So cervical incision is preferred for removal of retrosternal, substernal or mediastinal goiter. Before discussing anything else, I want to tell you certain definitions that sometimes you people are confused between what is radioactive iodine uptake, what is radioactive iodine scan or thyroid scan, what is hot nodule and what is cold nodule. Now very simple. Suppose you are giving 100 grams of radioactive iodine to someone to swallow. If any patient swallowed 100 grams of radioactive iodine and the thyroid gland took 70 grams, so tell me how much is the radioactive iodine uptake? It is 70%. So what is the definition? It is amount of radioactive iodine taken by thyroid within stipulated period of time, that is 6 to 24 hours. I'm repeating. Radioactive iodine uptake is amount of radioactive iodine taken by thyroid within stipulated period of time, that is 6 to 24 hours. Now I don't know in which part of thyroid there was uptake of radioactive iodine. Now imagine that I'm going to scan this thyroid region with gamma probe. I'm going to scan this cervical region with gamma probe. This scan is known as radioactive iodine scan, also known as thyroid scan. So what is thyroid scan? Scanning of cervical region with gamma probe for radioactive iodine uptake. Now see, on this thyroid scan or radioactive iodine scan, if one nodule collect radioactive iodine more than surrounding tissue, this is known as hot nodule. And if there is one nodule which collects radioactive iodine in comparison to surrounding tissue, less radioactive iodine in comparison to surrounding tissue, this is known as cold nodule. So I'm repeating, hot nodule which collects more radioactive iodine in comparison to surrounding tissue. How much is the risk of malignancy in hot nodule? It is 1 to 3%. What is cold nodule? Which collects radioactive iodine lesser than the surrounding thyroid tissue. How much is the malignancy? Risk of malignancy in cold nodule 17 to 20%. These are very, very important questions. After that, I want to tell you what are the types of thyroidectomy. So have a look. Types of thyroidectomy. So this is thyroid gland. Now you see, in the first, if I'm going to remove the whole thyroid gland, removal of whole thyroid gland, this is known as total thyroidectomy. Removal of one lobe with isthmus. Removal of one lobe with isthmus is known as hemithyroidectomy. Sometimes one word is used for hemithyroidectomy, and that is also known as lobectomy. So removal of one lobe with isthmus is hemithyroidectomy. Now have a look. If I am going to remove the thyroid gland with leaving 4 to 6 grams of thyroid in each lobe superiorly, this is known as subtotal thyroidectomy. So leaving 4 to 6 grams of thyroid tissue in each lobe superiorly with removal of rest of the thyroid gland. This is subtotal thyroidectomy. After that, see, suppose we are going to leave 10 to 12 grams of thyroid in one lobe and removal of rest of the thyroid gland. This is a modification of subtotal thyroidectomy known as Hartley Dunhill procedure. I'm repeating, leaving 10 to 12 grams of thyroid in one lobe with removal of rest of the thyroid gland is known as Hartley Dunhill procedure. And what is near total thyroidectomy? Is leaving small remnant of thyroid tissue in tracheoesophageal groove. Leaving small remnant of thyroid tissue in tracheoesophageal groove, and that is near total thyroidectomy. So these are the types of thyroidectomy. After that, lots of questions are asked that in which particular condition total thyroidectomy is performed, hemithyroidectomy is performed, subtotal thyroidectomy is performed. So see, total thyroidectomy is usually performed for thyroid malignancy or benign disorders involving both lobes. So it is performed for thyroid malignancy and benign disorders involving both lobes. Total thyroidectomy. After that, hemithyroidectomy. Hemithyroidectomy is performed for benign disorders involving one lobe. Benign disorders involving one lobe, we perform hemithyroidectomy. Now, what is the indication of subtotal thyroidectomy? See, 50 to 70 years back, surgeons were performing subtotal thyroidectomy for multinodular goiter. But what happened? When prolonged follow-up was done for 20 to 30 long years, it was seen that there was recurrence from thyroid remnant. And if there is recurrence from thyroid remnant, it's very difficult to remove it in second surgery. Why? Because anatomical landmarks are lost and there is excessive fibrosis. It increases the risk of recurrent laryngeal nerve palsy. That's why nowadays subtotal thyroidectomy is reserved for the patients in whom there is no recurrence after 20 to 30 years. It means which patient? Elderly. So subtotal thyroidectomy is performed for multinodular goiter in elderly. Multinodular goiter in elderly. So I'm repeating, 50 to 70 years back, surgeons were performing subtotal thyroidectomy for multinodular goiter. But when prolonged follow-up was performed, there was recurrence from the thyroid remnant. That's why only indication for subtotal thyroidectomy is multinodular goiter in elderly. So these are the types of surgery. Sometimes we are using the word total oblique near total for thyroid malignancies and benign disorders involving both lobes. See, preferred treatment options will be total thyroidectomy. After that, questions are asked regarding solitary thyroid nodule. So first question, what is most common solitary thyroid nodule? The most common solitary thyroid nodule is colloid goiter followed by follicular adenoma. Questions are asked, what is the first investigation done in solitary thyroid nodule? The first investigation done in solitary thyroid nodule is thyroid function test. What are the components? There is TSH, there is T3 and there is T4. After that, question is asked, out of T3, T4, TSH, which one is most informative? And that is TSH is most informative. Why? Because of ultra sensitivity. So because of ultra sensitivity, it is most informative. It can detect subclinical hypothyroidism and subclinical hyperthyroidism. What is the meaning? Even if patient is not having signs and symptoms of hypothyroidism or hyperthyroidism, what happens? In hypothyroidism, there is elevation of TSH, and in hyperthyroidism, there is decrease in level of TSH. So we can diagnose subclinical hypothyroidism and hyperthyroidism. After that, what is the investigation of choice for diagnosis of solitary thyroid nodule? This is very important question, and that is FNAC. After that, questions are asked, what are the limitations of FNAC in thyroid swellings? Limitations. So first limitation, it cannot differentiate. It cannot differentiate follicular adenoma from follicular carcinoma. Follicular adenoma from follicular carcinoma. Question, why? Because the diagnosis of follicular carcinoma is based on vascular invasion and capsular invasion. Vascular invasion and capsular invasion, which is not detected on FNAC. It can be only diagnosed on biopsy. That's why FNAC cannot differentiate follicular adenoma from follicular carcinoma. Second limitation, Hashimoto. Second limitation, Riedel's thyroiditis. Riedl's thyroiditis. In Riedl's thyroiditis, the thyroid tissue is replaced by fibrosis. That's why FNAC is not going to diagnose this condition also. And third is thyroid lymphoma. The diagnosis of thyroid lymphoma is made by biopsy. So these are the limitations of FNAC. So these are the investigations which are performed in solitary thyroid nodule. So you know the treatment options, you know the investigations. So let us discuss what's the management of solitary thyroid nodule. So have a look. Management of solitary thyroid nodule. The investigation of choice for diagnosis is FNAC. After FNAC, there are 4 possibilities. First, it is inconclusive. Second, it is benign. Third, it is suspicious. And fourth, it is malignant. Only there are 4 possibilities. See, if it is inconclusive, we have to go for what? Repeat FNAC. For benign lesions, there are 2 possibilities, whether there is cystic or there is solid lesion. If there is cystic swelling, we will go for aspiration. And suppose there is recurrence after aspiration, usually re-aspiration is performed. Maximum for how many times re-aspiration is performed? 3 times. After that, if there is recurrence, we perform hemithyroidectomy. Now see, for solid lesions, initially we consider thyroxine therapy, because sometimes what happens, the swelling disappears. But if it persists, or there is no response, or there is compression symptoms. So if swelling persists or there is compression symptoms, in that case we perform what? Hemithyroidectomy. For suspicious lesions, we have to perform radioactive iodine scan. After radioactive iodine scan, 2 possibilities are there. 1, hot nodule. Second, cold nodule. Cold nodule doesn't take radioactive iodine, so we have only one treatment option for cold nodule. And what's that? That is hemithyroidectomy. For hot nodule, we have 2 options. One is hemithyroidectomy and the second option is radioactive iodine ablation. For malignancy, you know that the treatment is total thyroidectomy. So this is how we manage the patients of solitary thyroid nodule. Now, lots of the questions are asked about radioactive isotopes and radioactive iodine ablation. Right? So have a look. What are the radioactive iodine isotopes are used? One is iodine 123. What is the half-life of iodine 123? 13 hours. And second, iodine 131. What is the half-life of iodine 131? That's 8 days. If iodine 123 is having shorter half-life, that's why it's used for diagnostic purpose only. And since iodine 131 is having longer half-life, that's why it is used for both diagnostic as well as therapeutic purpose. That is radioactive iodine ablation. So, iodine 131 is used for radioactive iodine ablation. Lots of questions are asked about radioactive iodine. ablation. So, the first question, what is the isotope used? That is iodine 131. This iodine 131 emits what? Beta rays and gamma rays. How much beta? 90% is beta and 10% is gamma. Questions are asked. Which of the following rays are responsible for therapeutic effect, and which one is responsible for side effects, and which one is used in tracer studies? Beta rays are responsible for therapeutic effect, means for the ablation of thyroid, and gamma rays are responsible for side effects. Simultaneously, it is also used in tracer studies like radioactive iodine scan. After that, questions are asked, how much is the depth of penetration of beta rays? The depth of penetration of beta rays is 0.5 millimeter. It is so low that even parathyroids are not damaged. Now you can see this patient who is receiving radioactive iodine, especially iodine 131, that person is emitting gamma rays. And that's why there are two absolute contraindications for radioactive iodine ablation. And that is what? One is pregnancy, and second is lactation. Why? Because there is direct exposure to the fetus. Gamma rays, okay, are emitted from the patient, and in this pregnant patient or in lactating females, there is direct exposure to the fetus. That's why these are absolute contraindications. After that, we are going to discuss hypothyroidism and hyperthyroidism. By the way, I want to tell you one basic concept. What's the function of thyroid hormones? Function of thyroid hormone. Thyroid hormone converts mass into energy. If thyroid hormone converts mass into energy, patient is suffering from hypothyroidism. It means that patient is having only mass in the body, no energy. So you have seen hypothyroid patients who are having weight gain. They are not having active energy. They are having lethargy. Now just opposite in hyperthyroidism, mass is converted into energy. That's why usually the patients of hyperthyroidism are lean and thin, but they are very active. So one simple principle, thyroid hormone converts mass into energy. Example, most common cause of hypothyroidism worldwide is Hashimoto's thyroiditis, and most common cause of hyperthyroidism worldwide is Graves' disease. So we are going to discuss Graves' disease. Other name of Graves' disease is diffuse toxic goiter. You know, this is an autoimmune disorder. If it is autoimmune, it means there will be autoantibody. So it is characterized by autoantibodies against. So there is thyroid stimulating, autoantibody against TSH receptor. Now have a look. This is TSH receptor. On this TSH receptor, which hormone is working? Obviously TSH. Because of this, there is release of T3 and T4. What's the problem in this case? This thyroid stimulating autoantibody is going to stimulate this TSH receptor. Because of this, what will happen? There is increased release of T3 T4. And can you see, because of increased release of T3 T4, there is feedback inhibition. So there is decreased levels of TSH. So it is characterized by increased T3, increased T4 and decreased TSH. It means patient is having what? Hyperthyroidism. Not only hyperthyroidism, actually the patient is having thyrotoxicosis. So this is an autoimmune disorder associated with autoantibody against TSH receptor. It is associated with HLA, B8 and DR3. It is characterized by diffuse toxic goiter, thyrotoxicosis, ophthalmopathy, ophthalmopathy means exophthalmos. So that is exophthalmos. Second, dermopathy. This is pretibial myxedema. Pretibial myxedema. And acropathy. Acropathy means subperiosteal new bone formation in metacarpals. Subperiosteal new bone formation in metacarpals. And gynecomastia. So these are associations with or characteristic features of Graves' disease. After that, coming to clinical features. Before discussing the clinical features, I want to tell you the basic concept. What? In patients of hyperthyroidism, there is increased expression of beta receptors. Because of increased expression of beta receptors, you have seen that most of the patients of hyperthyroidism are having sympathetic stimulation signs and symptoms like tachycardia, palpitation, excessive sweating, tremors, lack of sleep, mental irritation. What is the cause? Increased expression of beta receptor. So in patients of hyperthyroidism, there is increased expression of beta receptors, and these are responsible for sympathetic stimulation, signs and symptoms. So what are those sympathetic stimulation signs and symptoms? Tachycardia, palpitation, tremors, lack of sleep, mental irritation, and increased sweating or excessive sweating. So question is asked, what kind of tremors are seen in cases of sympathetic stimulation? Yes, it is fine tremors. And what is the location of fine tremors? Can you see in the fingers and in the tongue? So the kind of tremors seen, this very important question, fine tremors. And these fine tremors are seen in fingers and tongue. These are sympathetic stimulation signs and symptoms. After that, symptoms of hyperthyroidism. There is increased basal metabolic rate because of thyroid hormone. So because of increased basal metabolic rate, there is increased appetite. but there is weight loss, there is heat intolerance, there is excessive sweating, and increased thirst. Excessive sweating and increased thirst. So these are the signs and symptoms of thyroid stimulation. After that, what is the most common GI symptom, gastrointestinal symptom in patients of Graves or hyperthyroidism, and that is diarrhea. Most common GI symptom in patients of Graves disease, diarrhea. In young patients, which symptoms are predominant, and in elderly, which symptoms are predominant. See, in young patients, it's the CNS symptoms which are predominant, and in elderly, it is the CVS symptoms which are predominant. So, in elderly, you might find what AF and CHF. AF means atrial fibrillation, and CHF means congestive heart failure. So these are the manifestations which are commonly seen in young and elderly patients. In children, there is early growth and maturation. So there is early growth and maturation. What about females? In females, there is increased risk of abortions. There is amenorrhea and infertility. So, increased risk of abortions, amenorrhea, infertility in females. Here, you can understand that this thyroid gland is hyperactive. And if thyroid gland is hyperactive, it should require raw material also for production of T3, T4. It means there is increased radioactive iodine uptake. Simultaneously, if the gland is hyperactive, its vascularity should also be increased. That's why in Graves' disease, the gland is hypervascular. And the question is asked, this hypervascularity is most marked over which pole? It is at upper pole or near upper pole. So hypervascularity is most prominent near upper pole. If I'm going to palpate this region, what I can feel, there is palpable thrill. On auscultation, there is audible bruit and sometimes audible venous hum. So there is palpable thrill, audible bruit, and venous hum. One simple thing I want to tell you, in most of the thyroid swellings, investigation of choice for diagnosis is FNAC. I told you 3 limitations. 1. FNAC cannot differentiate follicular adenoma from follicular carcinoma. Second, Hashimoto's thyroiditis. And third, thyroid lymphoma. So usually in most of thyroid swelling, investigation of choice is FNAC. One simple concept, for autoimmune disorders, you can easily make the diagnosis by autoantibodies. That's why, since Hashimoto's thyroiditis and Graves' disease both are autoimmune disorders, I can easily make the diagnosis of these two in laboratory by measuring autoantibodies or by detecting autoantibodies. So here, usually I can make the diagnosis. But by the way, see, in this case, there is increased T3, increased T4, decreased TSH because patient is having hyperthyroidism and there is eye signs. Presence of eye signs in the patients of hyperthyroidism is usually confirms the diagnosis of Graves. Suppose eye signs are not there. In this case, there is increased radioactive iodine uptake. Why? Gland is hyperactive. And one single investigation which can confirm the diagnosis is presence of autoantibodies. So presence of thyroid stimulating autoantibodies against TSH receptor is diagnostic. So diagnosis is done. Now what is our main role? First, our main role is, suppose this is TSH receptor. Our main role is to decrease the production of T3T4. In this case, there is increased production. So I want to decrease the production of T3T4 first. That's why I will give what? Anti-thyroid drugs. For decreasing the production. Before use of anti-thyroid drugs, what's the first drug given in the patients of Graves' disease? And that is non-selective beta blocker propranolol. Why? I told you in the beginning that in patients of hyperthyroidism, there is increased expression of beta receptors. So to control sympathetic stimulation, signs and symptoms, we give non-selective beta blocker, and that is propranolol. So first drug given is non-selective beta blocker, propranolol. It is going to take control of sympathetic signs and symptoms. Second, we give anti-thyroid drugs to control the production of thyroid hormone T3 and T4. What are the anti-thyroid drugs which are given? Methimazole, carbimazole, and propylthiouracil. And propylthiouracil. There is a side effect which is frequently asked about these anti-thyroid drugs, and that side effect is what? Agranulocytosis. This is one. Second, methimazole increases the risk of aplasia cutis and choanal atresia. So this methimazole increases the risk of aplasia cutis and choanal atresia. What is the problem with propylthiouracil? It increases risk of hepatic failure in females and children. Second, there is one advantage of propylthiouracil, that it blocks peripheral conversion of T4 to T3. Lots and lots of questions are asked just on the basis of this important property. So what is the anti-thyroid drug of choice? Anti-thyroid drug of choice in pregnancy. So can you see? You cannot give methimazole because it increases the risk of aplasia cutis and choanal atresia. You cannot give propylthiouracil because it increases the risk of hepatic failure. So what is the anti-thyroid drug of choice in pregnancy? It is carbimazole. Let me tell you, in some books it is not updated yet. In some books, it's still given Propylthiouracil, which is wrong. The correct answer is carbimazole. After that, second question. Anti-thyroid drug of choice in thyroid storm. If there is thyroid storm, then anti-thyroid drug of choice is what? Propylthiouracil. Why? Because of this special property. It blocks peripheral conversion of T4 to T3. So second question. Anti-thyroid drug of choice in thyroid storm. And that is propylthiouracil, PTU. Third question. What's the anti-thyroid drug of choice in Graves? Anti-thyroid drug of choice in Graves' disease. And that is Methimazole. Anti-thyroid drug of choice in Graves' disease, Methimazole. These are three very important questions. I'm repeating. Anti-thyroid drug of choice in pregnancy, carbimazole. Anti-thyroid drug of choice in thyroid storm, propylthiouracil. And anti-thyroid drug of choice in Graves, Methimazole. Now coming to Graves again. In the Graves' disease, we are giving anti-thyroid drugs. And because of this, patient becomes asymptomatic within 2 weeks. And patient becomes euthyroid within 6 weeks. So asymptomatic within 2 weeks, euthyroid within 6 weeks. What is the problem with anti-thyroid drugs? You cannot continue it and it's not a definitive treatment. Why? Because the moment you are going to stop anti-thyroid drugs, there is recurrence. So what's the main role of anti-thyroid drugs? These are given to prepare the patient for surgery or definitive treatment. It means these are given to make the patient euthyroid. So anti-thyroid drugs are given to make the patient euthyroid. After that, there are definitive treatment options. First, radioactive iodine ablation, in which case we will go for radioactive iodine ablation, the conditions where we cannot perform surgery, like elderly patients. Second, patients with comorbidity. And third, recurrence after surgery. So if there is recurrence after surgery, in these cases we have to go for radioactive iodine ablation. Questions are asked, what are the contraindications of radioactive iodine ablation? There are two contraindications. First, absolute, and second is relative. What are the absolute contraindications we discussed? First is pregnancy, and second is lactation. Why? Because there is exposure of gamma rays to the fetus. What are the relative contraindications? Young patients. Second, smokers. And third, ophthalmopathy. Young patients, smokers, and ophthalmopathy. Why young patients? Because I don't want to expose the patient to the gamma rays. Smokers and ophthalmopathy. In these two cases, after use of radioactive iodine, there is actually worsening. In smokers and ophthalmopathy, there is worsening of ophthalmopathy. So these are relative contraindications. One simple question: what are the indications of surgery? So you can see the contraindications of radioactive iodine ablation are indications for surgery. So the indications for surgery are these five. Apart from that, the sixth indication is what? Large nodule or having suspicion of malignancy. So I'm repeating, what are the indications of surgery? In graves, pregnancy, lactation, young patients, smokers, ophthalmopathy, and large nodule or suspicion of malignancy. So you tell me, what's the treatment of choice for Graves' disease? And obviously, it's total thyroidectomy. Why? Because it is diffuse toxic goiter involving almost whole thyroid gland. So the preferred treatment or the treatment of choice is total thyroidectomy.